Please bear with me if I repeat some of the talks that are done earlier, but I think the importance is still there. I'll be talking about progression artifacts and non-glaucomatous progression. Central to the issue of a visual field progression is a lack of consensus on what actually constitutes a clinically significant change in the visual fields. And when we find a change, we have to decide whether the change is real or is it artifactual. And unless a true change in a glaucomatous visual field is larger than the combined short and long-term fluctuations as we discussed, it becomes statistically indistinguishable. Some of the common artifacts which we can encounter in a single field printout or in the follow-up printouts could be as follows. It could be a clover leaf pattern because of the centering of the 4 cardinal points first. After that, the patient comes inattentive and you find a clover leaf pattern. It could include white scotomas, what you can see here. The GST shows abnormally high sensitivity, there are false positive errors, and the thresholds are around 40 to 45, which is humanly impossible to achieve. A follow-up visual field showing a peripheral artifactual defects here, which are probably related to the lens, because we can notice that the test has been done with the contact lens in the first place and has been done with the trial lens in the second. Another one, for a frosted lenses, we can see some nasal defects there, and another form of a common defects could be because of the ptosis, can have superior defects because of the ptotic lids. A significant change in this visual field, which was done earlier in follow-up, you can notice that there is some change there. And we find that high amount of fixation losses in the second visual fields. And then we finally realize that the test has been done for the left eye, but somebody had noted the right eye, and that is why there is a false tracking of the blind spot and high number of fixation losses because of that. And we repeat the visual fields, they come out to be normal. As we have already discussed about the visual field index, we may sometimes find a sudden change in the visual field index because of the change in the mean deviations. Notice the change, this is a fairly stable sort of patient, the intraocular pressures are under control. And we notice that in the first picture, in the second visit, we can notice the pattern deviation plot, and it is not shown in the third one. It is because the mean deviation has crossed the threshold of 20 decibels. It takes beyond the 20 decibels, it will show that the pattern deviation is not shown. Along with that, we find there is a change in the visual field index, which goes from around 43% to 29%. So is there the change is real or artifactual? I believe it's artifactual because of the strategy how the visual field index is calculated. Initially, it will take the pattern deviation into account, and later on, beyond the 20 decibels, it will take the mean deviation into account. And just because of the way it has changed from 19.74 to 20.83, we find a change in the VFI, even though the patient has a stable 10-2 visual fields. Some people may have a very prolonged learning curve. The test done in 2003, and over a period of 6 years, the patient performs inconsistently. He has a healthy optic disc, and finally in 2009, he gives a fairly normal sort of visual fields. These are all artifactual. However, we have talked a lot about statistics. Everything is not about statistics. Take the 60-year-old woman who has a pressure of around 16 and 18 and fairly normal-looking healthy discs and has been on anti-glaucoma medications for the past 3 years. Visual field losses show advanced field effects in both the eyes and still has an apparently normal discs on the follow-up visits. The GPA, what we did, shows a likely progression done on 3 visits. Shows a likely progression for the right eye and shows a likely progression even for the left eye. And finally, she gives a fairly normal sort of a picture in the final visit. And then we see the GPA, it shows that it is fairly normal and there's not much change from the very beginning. So basically all the defects that we saw, the progression that we saw was artifactual, didn't correlate to what we saw on the optic disc. So what to do? What to do with these situations when we have this sort of picture? Number one, establish a baseline, as we have discussed, have 2 or 3 visual fields over a short period of time. And whenever there is a progression, as we have already stressed, establish a suspected progression. Repeat the visual fields within a shorter period of time. However, a very too frequent perimetry may also cause an increased number of false progresses. So we need to decide how much of visual fields are actually required. Don't do it at a very frequent interval, you do it every week or something, do it and trying to find out any progression there. But a failure to confirm a progression is also sufficient to consider a perimetry stable. That is given by the World Glaucoma Association consensus statement. If you are not able to confirm that there is a progression, consider the visual fields as stable. This has already been reported. There's a retrospective study in which there were 6 trial-based progression criteria taken, and then visual fields were noted to be infrequent, in the sense that over a period of time, when you have follow-up 1, follow-up 2, and follow-up 3, we find that around 50%, first visit, around 25% to 50% of patients do not have do not confirm the suspected progression what we saw in the very first visit. So unless and until you confirm that there is a progression over repeated testing, don't think there is a progression there. Rule number 2, what do we expect from this visual fields? Have a strong structure function correlation to what we see on the optic disc. This is what we see on the optic disc. Do I get the same sort of picture on the visual fields? So this sort of patient who comes to us, fairly normal looking optic disc, do a visual fields, and we find that the test has been done fairly reliably, and we find that there is some pattern deviation. Somebody has marked it. There's some pattern deviation defects are there. The glaucoma hemifield test shows outside normal limits. So it's written there on the file, pattern deviation is present, test is reliable, GST is outside normal limits. Patient is labeled as glaucoma and is asked to use anti-glaucoma medications. Chalta rahega. It will continue lifelong. We need to correlate what we are finding out. We don't expect this sort of visual field defects. We repeat this test. Try to find out whether it's correlating to what we see on the optic disc. Another picture, fairly normal looking optic disc, physiological cupping and advanced field losses. Repeat it. It's normal. Rule number 3, establish the prior probability of progression before we actually do the visual fields. Is it a well-controlled glaucoma clinically, or it's a poor control of having an advancing sort of a disease? The clinical inputs could include the intraocular pressure, the disc hemorrhages, the disease stage, and imaging. Another example here, we can see that there has been a slow progression over time. You can see the increased amount of defects there. And there is definitely a disc hemorrhage at this point of time when the patient came. So things correlate. Patient is progressing, and we have the evidence for that. And if we find the progression to be there, is it glaucoma that is causing that progression, or there's something else that needs to be done? Localized subcapsular cataracts, retinal lesions, or disturbances of higher visual pathways may also be responsible. Rule out that if you're not able to find out a reason for that. Does not correlate. What to do? Is there any other reason that is responsible? Neurological, try to explore other reasons why you find the change there. Usually neurological lesions affecting the higher visual pathway tend to respect the vertical midline. Fairly normal looking discs. The patient has these defects. This is not related to glaucoma. It is related to a brain infarct in the past. A 45-year-old male patient with a gradual, painless, progressive decrease in vision. Vision is 660 and 69. Pupils are brisk, no RAPD. Fairly healthy looking optic discs, but has nearly 3-quadrant defects in both the eyes. The reason? There's a pituitary adenoma there. Patient undergoes a surgery and comes back with a fairly normal sort of an optic disc and a regressing lesion there. A suspected inflammatory optic neuropathy in the left eye. The patient comes to us earlier, fairly normal looking optic discs, comes back again for a follow-up, and there is an increased defects in the left eye. These usually are central or paracentral because it's suspected optic neuropathy. Patient is started on systemic steroids for the treatment and it's probably better. So before we do anything, making clinical decisions based alone on statistical analysis should be avoided, and analysis should be done in alignment with the clinical impression and should be a part of multifactorial decision-making process. Thank you.